Good afternoon and welcome to the 148th of the COVID calls. This is a daily discussion of the COVID 19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at Drexel University in Philadelphia. Today, we will discuss the history of pediatric AIDS and talk about lessons from that history that help us see the COVID 19 pandemic more clearly with Jason Chernesky, Janet Golden, and Stephen Pemberton. Just a reminder, you can catch COVID Calls live every weekday at 5 p.m. Eastern Time on YouTube. Just go to the COVID Calls YouTube channel to watch. You can also watch COVID Calls on Facebook Live and on Periscope. You can hear COVID Calls anytime recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID Calls via Twitter using the handle @US of Disaster or @COVID Calls. Please do help spread the word and send suggestions for future guests and topics, and please feel free to suggest yourself as a future guest. As of today, October 14th, 2020, there are 1,088,463 deaths from COVID-19 globally, according to the Johns Hopkins University Coronavirus Resource Center. There are 7,870,653 cases in the United States. That's up from 7,817,863 cases reported yesterday. There are now a total of 216,169 deaths reported in the United States from COVID-19. That's up from 215,355 deaths reported yesterday. As a way to bring some humanity to the numbers, I've been reading a life story or a story of advocacy for those impacted by the pandemic, and I'd like to continue that now. The headline: "He is 16 and his mother died of COVID-19. What happens to him now?" by Nikita Stewart. This appeared in the New York Times, August 13th, 2020. I'll put the story up on Twitter because you'll also want to check out the photographs, remarkable photographs by Gabriela Bhaskar that accompany this article. For the Friesen brothers, the year had begun on a hopeful note. They had finally reunited with their mother, Beatrice McMillian, after years of being in foster care. Ms. McMillian had secured rental assistance for an apartment so she could move out of a homeless shelter. The older brother, Kassan, was embarking on adulthood, working at Whole Foods and attending community college. The younger brother, EJ, was living with his mother and doing well in high school. Then in April, Ms. McMillian died of COVID-19. Her death shattered everything the family had gained. Mr. Friesen, 22, headed to court to try to become his 16-year-old brother's guardian and keep him from returning to foster care. "He needs someone, and I'm going to be that person," said Mr. Friesen. When the coronavirus pandemic killed thousands of people in New York City, it made orphans of an unknown number of children. At least 8 children have been placed in foster care because their parents died from the virus, according to the City Administration for Children's Services. The total number is likely higher. Children and families with more money or wider support systems usually handle guardianship issues privately. The sudden loss has thrust some young adults like Mr. Friesen into the unexpected role of surrogate parent, fighting to keep what's left of their families together. Your physical home is gone, your emotional home is gone. Then you're going to be put with someone you've never known in your life, said Karen J. Friedman, the founder and executive director of Lawyers for Children, which represents children in foster care, including some whose parents died in the pandemic. That is a terrifying process for any child. Jessica Barrera, 16, faced the prospect of losing her home this spring. Her father died of tuberculosis in March, just as the virus was erupting in New York. Jessica's mother, Maria Arizaga, who worked in a bakery, was worried about how to care for Jessica and her older brother, Luis. Her parents had immigrated from Ecuador and did not have close family in Brooklyn where they lived. At the funeral, Ms. Arizaga turned to a family friend, Cesar Sevillo, and remarked that her children would now belong to him. It was the kind of brief, emotional remark that a grieving person might whisper in the moment, and Mr. Sevillo politely nodded. Only weeks later, Ms. Arizaga died of COVID-19. Her son, Luis, began desperately looking for an adult to be a guardian to Jessica so that she would not be placed in foster care. At 19, he was about 2 years too young to be considered for the role. The last time I spoke to my mom on the phone, she said, "If anything happens to me, just take care of your sister, okay?" Mr. Barrera said. "I had to be the responsible one for my sister." He turned to Mr. Sevilla who had just recovered from the coronavirus himself. Mr. Sevillo then asked his sister Laura to help. Ms. Sevillo, who has her own teenage daughter, said she had to establish remote learning for Jessica, take her to the doctor, make sure she was eating, tasks that Luis, who worked at a supermarket and attended college, could not handle on his own. He also had to plan a trip to Ecuador, where he and his sister took their parents' ashes in July. A judge granted temporary guardianship, which will likely be extended, but the judge will have to ultimately decide who will be Jessica's permanent guardian. Mr. Freisen was determined to prevent his brother EJ from having to return to foster care. The brothers went into the care of the state in 2013 after their father died of prostate cancer. Their mother, Ms. McMillian, was in prison serving a sentence for manslaughter. But Ms. McMillian, who killed her boyfriend in a domestic dispute in 2009, was a fierce protector from prison, Mr. Freisen said. She monitored the welfare of her sons in phone calls to foster parents and agencies. She pushed to get her sons moved into a more suitable home when they told her they were having problems with one foster mother, Mr. Freisen said. When Mr. Freisen learned his mother had coronavirus and would be hospitalized, he immediately went to the homeless shelter where his family was staying in Kips Bay and got his brother. Doctors ordered them to quarantine for 2 weeks in his apartment on the Lower East Side, so they were unable to visit their mother before she died in the hospital. He reached out to Lawyers for Children, which had represented them in the past. The group referred him to a private lawyer, Philip Katz, who said a judge recently awarded Mr. Freisen custody, although there are still complications. Mr. Freisen cannot have overnight visitors for long stays at the supportive house building where he lives, so EJ sometimes has to bunk with relatives. Mr. Freisen has applied to move into a larger apartment in the building so the brothers can live together full time. Mr. Freisen said his mother would have wanted them to stay together. She was a good mom, he said. Okay, I'd like to turn to our conversation for today. We have a really great conversation planned. 3 experts today, and I want to introduce them. Jason M. Chernesky earned his PhD in the history and sociology of science at the University of Pennsylvania. He studies the histories of healthcare, children's health, public health, and environmental history in the 20th century United States. His dissertation, just defended, The Littlest Victims, Pediatric AIDS, and the Urban Ecology of Health in the Late 20th Century United States, explores what happens when a disease associated with the taboo behavior of adults begins affecting infants and children. Pediatric AIDS was a disease of poverty, which became closely associated with the multiple problems of the inner city, an urban geography that, for many Americans, was situated elsewhere. Jason's other scholarly interests include urban history, public history, and cultural history. Dr. Stephen Pemberton is faculty in history at the New Jersey Institute of Technology and Rutgers University, Newark. He's a historian of medicine, disease, and health with expertise in United States history and the history and sociology of science. His research and teaching is also informed by his training in philosophy and his engagements with medical humanities scholarship and health policy debates over the past 25 years. His book, The Bleeding Disease, Hemophilia and the Unintended Consequences of Medical Progress, appeared with Johns Hopkins University Press in 2011. Janet Golden, PhD, is Professor Emerita of History at Rutgers University. She specializes in the history of medicine, history of childhood, women's history, and American social history. She's the author or editor of numerous books and articles, including Babies Made Us Modern, How Infants Brought Americans into the 20th Century, out with Cambridge Press, Message in a Bottle, The Making of Fetal Alcohol Syndrome with Harvard Press. She co-edits the Critical Issues in Health and Medicine series at Rutgers University Press and is the recipient of many grants and fellowships, including those awarded by the National Institutes of Health, the National Endowment for the Humanities, the Commonwealth Fund, and the American College of Obstetricians and Gynecologists. Jason, Stephen, and Janet, thank you so much for making time to join me on COVID Calls today.
Thank you, Scott.
Happy to be here.
Thank you.
This is a powerhouse medical history team here today. I've really been looking forward to this call, and I've learned a lot even in just preparation for it. And I'd like to start the way we usually do, which is really just find out where you're all calling from and what the pandemic is looking like there today, and then we'll turn to the subject area for today. Jason, can I start with you, please?
Sure. technically calling in from West Philly, and Janet's also in Philadelphia, so we may have the same information. I think everything is okay over here, as it can be. I actually rode the bus for the first time since March today to get to campus. I thought that was very interesting. Everyone was wearing masks. The whole thing was set up very well. It was very nice. And Janet could correct me or not on this, but it also seems like Philly's done a pretty good job of keeping the numbers down since June. I mean, it's been okay, and people are wearing masks and keeping socially distant and everything. But I haven't been doing a whole heck of a lot outside except for running, walking, and that's about it, because I've been finishing the dissertation and inside either this room or my other 2-room apartment in West Philly. So, that's about it.
I guess if there is a time to be locked down, finishing the dissertation is that time.
Yeah.
What about campus though? Penn's not open at all, only for graduate students. What's the situation there?
It's not open at all, really. I mean, students are off campus. They're not on campus. I'm TAing this semester, so we're doing all remote teaching, right? We have to do these like daily check-ins online. So when I come into the office, like at where I am today, I have to show the security guard in our building. We have to make sure we have no symptoms. There's limited capacity in buildings. I can't speak for the whole university, just here, but I could tell you in our building, there's, I don't think I see more than 2-3 people a day. Yeah.
Janet, same question to you. Where are you calling from, and how's it looking?
Well, I guess I could say I'm on the other side of the river, not the track, here in Philadelphia, in the Fairmount neighborhood. I check the site COVID Act Now every day. Because now that I've retired, I do some political work, and I need to know where it's safe to maybe send volunteers or not so safe. So Philadelphia had kind of gotten into the outbreak imminent stage for a while, but I note today our conveyance rate is under 1.0. So we're doing a little better today, but Pennsylvania is now in a kind of riskier place than it was more recently, as is much of the country. And we'll have to see what happens in the coming months. I'll add that I did get my flu shot, and I hope everybody else does too.
I had mine. Just to follow up on that, what's your sense of that, Janet, that this is sort of the expected second wave because people are spending more time indoors, or this is opening of some schools, or some other factors that we can't put our handle on? Because what you've described is also the situation in New Jersey too. We're starting to see that edge back up where we don't want to be.
It's hard to know whether it's people are going into restaurants a little bit, or indoors a bit more, or meeting in groups a bit more. Or today I think it was I can't remember where I saw it, the drier air now that the heat's come on in the winter, apparently keeps those aerosols moving more indoors, keeps them alive a little longer. So we're kind of at the beginning of maybe a second wave. Maybe there'll be a third or a fourth. We just don't know.
Thanks for that, Janet. And so we've got Philadelphia locked down today. Stephen, where are you calling from?
Well, I work and teach in Newark, New Jersey, but I'm actually calling from central New Jersey, where I live, in the borough of Highland Park. And Central Jersey has not been that fortunate recently. We are having a very clear surge. I have right before me here a email that the mayor of Highland Park sent out yesterday. And she's reporting that, sadly in the last week, we've had 20 confirmed cases. If you stretch that back about 14 days, our numbers now are where they were in April at at the peak in Highland Park. And the trend is it's trending younger. And I think this is the real concern. About 10 days ago, 50% of the new cases were 19 and under in Highland Park. And whereas the average age of the 20 confirmed cases currently is 27, with ranging from age 3 all the way up to age 69. It's a little bit concerning. The surge is enough that the Highland Park schools have stopped their, they had a phased reentry plan to in-person teaching. And so they were supposed to start on October 1st with the kindergartners, the pre-K to the 3rd grade, coming back to the schools. Well, they couldn't, they postponed that because we didn't meet our target numbers because of the surge. And, you know, it's sort of an interesting phenomenon. It's, you know, maybe we can get into this as to, you know, what the, you know, why are we seeing teenagers in particular and younger kids, the infection rate go up?
I just, since you also have some perspective on Newark, I expect you haven't been back on campus, although you can correct me if you have, but I'm curious to know how you're viewing Newark right now in terms of sort of longer term recovery, because it's one of those places that I know was hit extremely hard in March and April.
Yeah, and I think, you know, relatively to where Newark was at, Newark is doing so much better. The schools and the campuses are mostly closed to students. They're doing remote learning. One of the exceptions is my primary institution, New Jersey Institute of Technology, where we do have, you know, several hundred students on campus, and we're doing an experiment in converged learning, which means that some of the students are allowed to come to the classroom with the instructor, and then some of the students are off-site remotely. I'll be actually starting to commute back into Newark in the spring because I've been assigned a converged modality. So that'll be an interesting experience. The outbreaks at NJIT have been controlled. The numbers actually in Newark and Essex County, at least around the campuses, are better than what we have actually in Central Jersey or certainly on the shore. Relatively speaking, I think Newark is, you know, holding its own right now, but the numbers are starting to become, you know, climb too.
Well, thank you for that. Thank you for those reports. So we're going to talk about COVID-19 in children, but to get to that, we're going to talk about some historical cases today. And Jason, I want to start with you and ask the first question to you, and actually just to sort of lay out some context for us, and to tell us a little bit about how the United States responded to the emergence of AIDS, but particularly AIDS in children, because I think, you know, culturally, anyone who was alive at that time or who's aware of that history, you know, they may not be familiar with the pediatric story in the United States. So can you situate us in that story?
I'm sorry, Scott. I lost you at the end there.
Did we break out? Sorry about that.
Yeah.
Just asking if you would. I think people may not be as familiar with that narrative of AIDS as something that was experienced by children. And so I'm wondering if you could just set that context out for us so we can understand it a little bit.
Sure. And I'm actually glad you read that piece from the Times about children being orphaned by the disease, because that was actually a big problem for children with HIV/AIDS, because so many of their mothers and fathers died from the disease and or were so sick they were unable to care for them. So they were often orphaned in hospitals and lived in hospitals for weeks and months, and in a couple rare cases, one child in Florida, I think, for a couple of years even. But to sort of take a step back, so typically, right, I mean, the grand narrative of the HIV/AIDS epidemic has focused largely on adults in the United States, particularly gay men, gay communities in some cities and elsewhere. And right around the same time that we start to see, we now know retrospectively that cases were being confirmed in the late 70s. The first actual case of pediatric AIDS retrospectively diagnosed was 1977 in New York City. But in New York, Newark, around the same time, in Miami, Florida, those three were kind of the epicenters of where the first cases were being seen or were saw by clinicians and clinical researchers at the time. So right around 1981, once the MMWR comes out in June of that year and shows that the first cases of pneumocystis pneumonia, or PCP, had killed 5 young gay men in Los Angeles, there were folks in Newark and in the Bronx that were seeing similar things going on with children, and they were like, "Wait, this looks very similar to what they saw in these adults is happening in these children." It took them a little while to get the studies out. From about 81 to 83, some scientists were a little skeptical. They were like, "I don't think this is HIV or AIDS." It wasn't HIV yet at the time, but around 83, the first cases were published in JAMA, in the Journal of American Medical Association, that showed that children were in fact contracting the disease. And these are children that weren't getting it from tainted blood products or blood supplies. So around 82, you did see that a little bit, and Stephen could speak more about this with children with hemophilia. But these were kids that were contracting the disease perinatally. So in other words, in utero or at birth. And the numbers were still relatively pretty low in 83. Right around 85 to 87, we see the crest sort of go up. And the connection to IV drug use was very strong with pediatric AIDS and heterosexual contact. So a lot of the women that contracted the disease usually contracted it through either IV drug use or sex or some combination of the two. And that's where we start to see around like 1987, we start to see a focus on a national focus on children with the disease, in large part because it was affecting these poor communities that were mostly communities of color in places like Newark and New York City. And that's like right around the same time. This is when you start to see the border, what they called the border baby crisis. So around 86, 87, you start to see these news stories popping up on the nightly news and in the newspaper. Politicians are starting to get a wind of this story of these children being orphaned in hospitals because like I said, their parents either died from the disease or were too sick to care for them. And they were also being orphaned or left in hospitals because a lot of people were scared to foster these children because they had this deadly disease, right? A, scared of potentially contracting the disease themselves, or B, the child was inevitably going to die. The case fatality rates for AIDS are quite high. They're over 50%. And so, yeah, and in addition to that, most of the children were poor Black and Latinx children. So getting them adopted was a real tough go for the first probably 6 years of the epidemic. Yeah, I don't know how much more context you want me to go. I mean, to give you the broad sweep, but I mean, like right around that same time, you start to see the first kind of federal responses to the disease. So the Abandoned Infants Act is passed in 1988. That's the first kind of real federal money devoted to pediatric AIDS to help this problem that I just call the border baby problem, to get them out of the hospitals, to get them into foster families and foster care facilities. Then, of course, you have the Ryan White Care Act, which was passed in 1990, which is the first big sort of massive, fund to help not just families and children with the disease, but everybody with the disease. But to go back to your initial question about the response, what's really interesting is, we could maybe talk a little bit about the similarities and dissimilarities with COVID, is that the first sort of few years, the story, the narrative that you see, especially in mass media and public conversations about it, was really kind of around a medical mystery. It's like, here's this disease affecting adults that's now affecting children. What's going on there? So there's this kind of medical mystery narrative. And then by the time you get to around 86, 87, when there is there's more focus on the disease in general, just across the board, you see Americans focusing on it, but also there are legislators, policymakers, pediatric AIDS advocates really pushing to get resources for these children. And this is where we see like this innocent victim narrative really starting to sort of drive some of the conversations, and some people pushing back against it because of the politics of the epidemic. And we could go in more detail there. So that's kind of like the first initial responses in those early years. And, we could, tease some of that out a little bit more if you want.
Well, no, thank you for that. And I guess I'm interested, maybe Janet, I'll bring you in on this, the degree to which what we can say about how pediatric AIDS may have been invisible to mainstream culture, what might have been the conditions, because it seems to have, if I've got you right, Jason, kind of been wrapped into broader narratives about parenting, around urban America, around race. And you're saying there's 10 years went by before there was some significant federal response in that regard. I'm sort of curious about that. So maybe, Janet, can you talk a little bit about the invisibility of pediatric AIDS in those early years?
Well, if you think back, if you're as old as I am, you can remember quite well that AIDS was situated as a condition that gay men brought upon themselves through their sexual activity, that drug users brought upon themselves through their injection drug use. It was a disease that signaled to many, many people in a highly political time that these people who were suffering were not victims, but victims of their own making. And as we discover children with HIV, the first narrative we want to lay on them is what Jason said. We want to say, oh, their parents did this to them. Their parents did it by injecting drugs, or their parents did it through their sexual behavior. And so we really have to make a turn to say, these are children. They didn't give it to themselves. They're the, quote, innocent victims. So how can we help them? How can we sort of sever them from the situations in which they live, in which their parents live, and the structural inequalities that creates these conditions, and present them as innocent victims so that we can get funding to them. And in many ways, that reflects a kind of historical experience where we'd have other epidemics, outbreaks, and we build orphanages, right? It's like we'll find what we'll call the innocent victims or the worthy people, and we'll build structures for them. And then perhaps from those structures, we'll grow a broader awareness of the conditions that people live in, of health and disease. But it's a long, long process. And I think what's different, perhaps, or what we're waiting to see with the COVID HIV situation comparisons now, is the international perspective, because we do start paying some attention to children and communities overseas who are massively affected by HIV/AIDS. We know that COVID is an international problem, and it'll be interesting to see if we somehow are able to leverage more funding, vaccine support, as some NGOs are doing and the World Health Organization is doing, to funnel COVID treatments or preventions overseas. And in fact, if we're going to use this sort of innocent victims model in that case, I guess we'll find out.
Stephen, let me bring you in. And I mean, it's so complicated, and I was living through that time too. And I mean, as Janet and Jason have explained it, you have sort of two simultaneous cultural moves happening. One of those is defining gay men as disease vectors, which plays into the existing homophobia of America. And then the other hand is the necessity to try to frame children separately in that discussion. And I know you've done research on pediatric hemophilia. Can you tell us that story a little bit and how it sort of wraps into what Janet and Jason were talking about?
Yeah, I think before I bring hemophilia into the dynamic there, I think what's really important, and this was understood at the time, certainly in the late 80s, when historians, cultural historians in particular, were beginning to look at the narratives of AIDS around this newly emergent epidemic. But, in retrospect, it's really important to understand, if we're going to understand the innocent victims narrative of that particular time, you have to kind of go back into the 20th century and understand how, sick children were framed. And Janet's alluded to this, but, we're all familiar, or many of us are familiar with the concept of the poster child. And, the legacy of, children, the children with polio, infantile paralysis, or children with leukemia or cancer, and their images being leveraged for resources, whether they're governmental or philanthropic, towards, in the case of the National Foundation for Infantile Paralysis and their March of Dimes campaign, these images of these children are used to raise money not merely for research, but also direct aid and treatment in the beginning in the late 1930s and through the 40s, up until the Salk delivers his kill virus vaccine, and they have the trials. So the thing is, by the end of the 1970s, before HIV and AIDS is visible as a phenomenon, sick children is this, like childhood itself, is this kind of trope, the embodiment of innocence. And you think about the war on cancer in the 1970s and how they were leveraging images of kids with leukemia and kids with cancer to help resource the broader campaign to develop research and bring public attention to cancer. All of this is going on before AIDS hits the scene. Now, the first pediatric AIDS cases that are documented by the CDC are really kids with hemophilia who need, transfusion therapy to help their blood clot. And the clotting factor concentrates that are being used with hemophilia patients, we now know were contaminated with HIV. They didn't know this at the time, but and there's what did they know when kind of very complicated story there. But already by 1983, 1984, it's very clear that something's in the blood supplies causing AIDS, that children are getting sick of it through transfusions. And these kids, these hemophilia kids, and many of them had had been raised in the 70s, born in the late 60s, 70s, and they were used to being treated as kind of held up on a pedestal as kind of ideal subjects. And Ryan White, who is the kind of prototypical face of pediatric AIDS in America, and later on in 1990, the whole federal response to AIDS is named after him. He's just died in 1990. But in 1984, late 1984, when he's first diagnosed, and he had prior to that been a poster child for hemophilia and in his local area of Indiana. Suddenly he finds himself with a disease that is heavily stigmatized. His family wants to get him back into school in the 85, 86 school year. He faces ostracism, and they don't allow him into school. He goes to court. Eventually, I think in the fall of 86, he's allowed to return to school, but then parents and children vote with their feet and walk out of school. They don't want to be in school with a child that's infected with AIDS. And at the time, he wins his battle in many ways, and he wins the battle in the public domain because of the press bringing attention to the discrimination against him. But I was always drawn to the work of Sander Gilman, the kind of cultural historian. As early as 1988, he writes about Ryan White, and I'm just going to quote him. He's saying that AIDS is already framed as, in these highly stigmatizing ways, as a sexually transmitted disease and as a drug of, as a result of drug use. So what do you do with these cases of pediatric AIDS? And the thing that he says the stigmatization at that point is so pervasive, widespread, that it permeates the categories of childhood, these categories of social organization, which would otherwise seem to be generally immune to these sorts of stigmas. So there's this battle over this young white, teenager, and it's very contested. The narrative that he and his family want out there is, I just want to live a normal life. The narrative that's out in the press is that there's these people who they don't want anything to do with pediatric, kids with AIDS because they're vectors of disease and particularly stigmatized diseases. There's even this language in the press where, and Gilman points this out, where the term hemophiliac gets transcribed with homosexual. So sometimes the word starts to be misprinted as homophiliac.
Right.
And the abuse that Ryan White took in school had this particularly vicious character, calling him gay, demeaning him. And, the record it's very clear in his autobiography and stuff that, that was a terrible year in his life. He ends up moving to another town. He moves from Kokomo to Cicero and has a new, more welcoming school. Also in 87, the other really infamous case is the case of three brothers in Arcadia, Florida: Ricky Ray, Robert Ray, Randy Ray. And they too go through this school battle. And once they're allowed to return to school, suddenly their family home catches fire and is burned to the ground. So after the fire of the Ray family, after Ryan White's on his feet and he's a celebrity and celebrities are coming to his door, Jason could talk about that. We see in 88 up till Ryan's death, the emergence of this kind of, image of this new kind of pediatric AIDS celebrity. Ricky Ray, Ryan White, they're celebrated in this context. But most kids with AIDS aren't like that. And I mean, Jason has a lot to say about that.
I just want to remind folks, thank you for that, Stephen. And I just want to remind folks that you're listening to COVID Calls. And today we're talking about pediatric AIDS and the analogy to COVID-19 with Janet Golden, Stephen Pemberton, and Jason Chernesky. So before we do make the turn to talk a little bit more about COVID, Jason, I do want to bring back this point that Stephen was making, that if Ryan White's story becomes sort of emblematic of pediatric AIDS, and I suppose if the focus becomes therapeutic and less about context, social context, then, what do you say to that? Who again becomes invisible? Which children become invisible if Ryan White is becoming the poster boy? Who's not? And I think that's, to me, understanding that is going to be a crucial part of the conversation around COVID, I think.
Yeah, I mean, thanks for bringing that up. The kind of racial erasure that happens, at least in the historical memory of the AIDS epidemic, is definitely seen in how many people remember Ryan White as the child. Matter of fact, I was TAing a class here with two big time biomedical scientists at Penn, and they had a guest lecturer come in, and we were chatting, and he's like, "So what do you work on?" I was like, "Oh, I'm writing a history of pediatric AIDS in the U.S." He's like, "Oh, Ryan White," and I was like, "No, yeah, not really, but So in other words, like that, right? That just symbolizes this kind of memory. Well, what's really important too is that the children that were born with HIV, number one, nearly 90% of kids with AIDS in the United States were born with the disease. And globally, that's also very high too, right? Most of the cases around the world are perinatally transmitted. 75 to 80%, 85% of the children in the US were Black or Latinx. Even today, even though the numbers are way down since 1994, when you have the introduction of antiretroviral therapies that actually reduce the transmission in utero. But still, the racial and socioeconomic disparities are quite high, and there's a corollary here to COVID, which I think we might want to touch on. But they weren't necessarily; these children weren't necessarily totally invisible. It's how Americans saw them, and between 1987 and 1992, pediatric AIDS really had its kind of like that. That was the time it was at the top of the public agenda. And those years might sound familiar to other American historians because that's also the convergence of other phenomena going on in the United States, right? You have the quote unquote crack epidemic and quote unquote crack babies, right? All these stories are being sort of intertwined at the same time in mass media. In fact, I mentioned the Abandoned Infants Act in 1988. That's actually was for both children that were taken from their parents that were using crack cocaine and who were left in hospitals, and children with HIV. But HIV became almost kind of the cover, so a political cover for that legislation to pass, because who's not going to be for sick, dying children, right? I mean, that was kind of the political calculus there. But this heightened degree of visibility was directly tied to conversations about the problems that many Americans saw in the quote unquote inner cities, right? Whether it was drugs, whether it was violence. This is also the time where the underclass is being used to describe the kind of subset of the poor in these areas, right? So the disease is attached to that. So that's the kind of visibility. And then once the country kind of moves on from those conversations, we see that pediatric AIDS is also no longer part of top of the public agenda. Plus, at the same time, people are moving on from the disease in general. But this idea of how, you were talking about therapeutics, but also, the memory of Ryan White also erases the conversation that was going on in the 1980s and 1990s, where you had pediatric AIDS advocates who were kind of rediscovering poverty as a structural cause for this disease. And that really percolated to the surface, right? So it wasn't just like, oh, kids are associated with poverty. You have literally people saying, no, it's the direct result of structural inequality. And then once the narrative goes down, and once we have a drug that helps reduce the rates, that sort of discussion disappears. Much way that Janet was saying with the orphanages, right, and how the construction of these institutions divorce or pull the child from these terrible places or quote unquote terrible parents. In 1994, you have a techno-scientific solution to do that. You have a drug, right? And it's able to sort of rescue the child and quote unquote rescue the child from these areas. But the strong correlation between the racialized health disparities and socioeconomic health disparities is really interesting because the numbers, the percentages are almost identical, right? 75% of kids now that are dying from COVID. I think the numbers, I saw one in one CDC, 121 deaths. And that's low relative to adults dying from the disease. But what's interesting is the national conversation is really focused on schools, right? So this low number of children with the disease is highlighting this sort of like politically contentious narrative about whether or not we should open schools or not. Forget about all the structural inequalities that are also, part of that problem. So I don't know if you want to, maybe Janet or Stephen want to chime in on that, but I think that particular connection is quite interesting.
Jason, just to make sure I understand too, this is going to be your book then. I mean, you're going to tell us how we actually were right on the verge of seeing structural inequality through pediatric AIDS, and then we just didn't. I just made it very, very simplistic, I think. But I mean, if I've just taken away from that really, I think, brilliant sort of explanation you were just giving, and particularly those years in the late 80s and early 90s, and I hadn't made that connection to crack babies. I mean, we're finding unworthy parents around every corner in 1990, 91, and they all just so happen to live in majority minority communities in cities that are the recipient of it by that point 12 years of federal disinvestment to the point at which they are literally falling apart. I'm thinking of Philadelphia at that point. I mean, correct me, I'm just trying to summarize kind of what you were saying there.
Yeah, no, you're right. And the book, forget about that for a second, but what's really interesting is the rediscovery of poverty. I think I'm stealing that from Charles Rosenberg. Janet could correct me if I'm wrong or not. I think I actually got that from him. Where there's these generations where particularly among health experts and healthcare professionals, where they're like, we got to do something about these other problems, or the disease is going to persist. And we're seeing that now. I think Mike Udell was even on your COVID calls talking about this, where public health, they're collecting lots of data about this, but there's no movement. And it'd be interesting to see if COVID does that. I don't know, right? I mean, it's still a big question mark.
Well, let's bring Janet in and see, what you think. And just to point out that some of these numbers, that the CDC August report indicated that African American and Latinx children are hospitalized at higher rates than other children. And as Jason said, maybe the number of children who've died has often been pointed to as low, as if that somehow shouldn't still startle us, but still over 5,000 children hospitalized, and majority of them were in communities of color and low-income communities. So, Janet, can you translate this historical lesson into COVID times for us?
Well, I think I'm going to go in a slightly different direction and say what is interesting to me is in the case of the polio children, the children with hemophilia who contracted HIV, the infants with HIV/AIDS, we had a lot of wonderful, what I'll call visual material, sympathetic looking infants and children and movie stars visiting them. Now with COVID, with a highly contagious disease where people are confined at home or they're confined in hospitals, the images we're getting of children are the ones going to Zoom school while their parents try and work. So we've shifted the visuals a little bit away from youngsters. We're getting a new sort of set of problems here. And the problem is people can't get to work. Not that, or these people, the kids or their elderly, they can't see their elderly parents, of course, these working people, but their kids might bring COVID home from school to them and they won't be able to go to work. It's a fascinating shift in the narrative, in part, I think, dictated by the nature of the virus and the fact that it's so highly contagious. But I wonder if that's going to change sort of the level of sympathy we start to build around children with COVID. And the other piece of that is because we can measure how many people are out of work, how many people overall are sick, how many people have spread it to others. Whereas the data for children is very inexact because we don't have a nationwide reporting system, different states use different methods. The problem of children is just not as visible. And we'll have to see where that goes going forward. But we're not going to have celebrities in hospitals visiting the children with COVID wards. So that may have some impact.
Janet, before we move too quickly past something you just said there, I think we have to linger on a second. You talked about the data problem. Can you tell us, just from your perspective, what is the data problem right now around COVID?
Well, the data problem around COVID is we don't have a uniform national reporting system. We don't have a federal site collecting the data, getting it out to every public health official and every school principal that needs to make decisions about it. Different states, particularly around the pediatric problem, are using different numbers. There's not a time of day when they have to report. We now see that there's excess mortality that overall that may be related to COVID, but we don't have a standardized way of measuring that. And when you do that, you can't get resources to the communities that need them because you don't know what the need is. So I think it's a terrible kind of problem. It was a little different. I think Jason can correct me if I'm wrong in the HIV/AIDS, because we did develop a blood test. We did know who had it. We did know the numbers who died from it. It was not a rapid death necessarily. So we've really kind of failed in sort of a first principle of public health, which is to get the data and to get that data out so it can be used effectively.
Can I say something real quick, Scott, if that's okay?
Sure, come on in.
Yeah, no, that's a great point. And, the American Academy of Pediatrics put out this report that kind of was compiling some of this data, and it's revealing. We were talking beforehand. Janet brought this up too. That it's revealing that how there is no standard for collecting, and with HIV/AIDS, it was not perfect, but it was much better. I mean, the surveillance, the HIV/AIDS surveillance system that was set up after '84 was pretty good. And you were catching there's a lot of cases that fell through the cracks, of course, but it was, like you said, it was a slow disaster. It wasn't a quick one. So people were able to get their hands on it a little bit better. But one of the interesting things about COVID in this CDC MNWR from September, in the discussion section, they actually show that like the data that they're using for this, right? Forget about the fact that it's not standard. The data that they're drawing from and to show the sort of inequities in death rates among Black and Latinx and Native American children. This is from when kids weren't in school, right? I mean, they weren't in crowded places. They weren't together in these other facilities. So like, what's going to happen, right? When you rush to open, and that kind of, it's very interesting that this comes out right before, the New York Times breaks a story about how the White House was, deliberately kind of pushing or leaning on the CDC to keep this information, maybe not, being fully sort of articulated for the public.
It's so amazing to me, but that we're still, there's so much to learn just about the virus itself. I mean, this novel coronavirus, but that also, the shutdown of the schools was so quick that we are, I think, at a terrifying sort of moment of learning right now about what's going to happen as students are reintroduced. And Stephen was talking about, the situation there in Highland Park, where they've sort of drawn back on that. But in other communities, I mean, my brother-in-law and sister are teachers in Austin, Texas, and there, it's exactly what Janet was describing and very clearly articulated. People need to get back to work. And in fact, it was framed as parents need to stop being overprotective, and because they need to get back to work, because we need to get Texas working again. I've heard this in Arizona, Georgia, and Florida as well. And that if we balance everything out, the health hardships of people not working is going to be greater than the COVID hardships of people going back into school and having the disease spread. Of course, it's hard to prove a negative there, but that's been the rhetoric. Stephen, let me bring you in on any part of what you've just heard that you want to comment on, but also I was really impressed with your, sort of educating us on the poster child effect. And I'm curious, what's the poster child of COVID right now? I mean, do we have in the United States, is there a model COVID sufferer? I haven't really thought about it that way till you were describing about that phenomenon.
Well, it's I don't know. That's a good theoretical question. As we transition from the spring and the summer, the model COVID person was, at the end of the aging cycle, right, in the nursing home, and you all are as have experiencing and can guess as well as I can what the answer to that question is. But I do want to come back to both what Jason and Janet said. Jason's emphasizing the fact that the numbers on COVID cases in kids are predominantly among kids of color. The ones that are really hurt most by a COVID infection tend to be Latinx or African American. And that looks eerily similar to the demographics of pediatric AIDS in the late 80s. And the structural problems are still there. Okay, so that's one commonality. But Janet's also right that the tropes around childhood have been flipped. This isn't, kids with COVID are not innocent by any means, right? They are vectors. And if the majority of the kids with COVID are the ones we're worrying about, then those vectors are the non-white kids. And that plays into all these stigmas about, immigrants and aliens and others, the other bringing infection into the community, and leads to a kind of narratives of containment. The other thing that's common between these dynamics, along with the persistence of the structural inequities, is images of kids are being leveraged for political reasons. So the arguments in Texas, and I grew up in Texas as well, so I'm very familiar with this. We need to get the kids back into schools. That's a political argument, right? It's a kind of playbook of how we should manage things. But it plays out on a notion of the child as a vector, and a vector of disease. So it's the underside of, let's say, the Ryan White story. It's not Ryan White, the innocent victim. It's Ryan White, the kid in your school that's going to contaminate you. So there's some really big dissimilarities between pediatric AIDS and COVID in kids, but the differences are illuminating to me as much as this kind of broader cultural and then structural similarities, and I don't have any answers, but we do have some analytical tools and data here that we could use to begin to figure out how should we be imagining the model COVID patient. I don't know.
Just want to remind folks that you're listening to COVID Calls, and you can get your questions in on the YouTube Live. Just put them into the chat there. You can get them up on Twitter. Just be sure to tag at US of Disaster. And I'm talking with Janet Golden and Jason Chernesky and Stephen Pemberton about COVID-19 in children and pediatric AIDS history and disease history. Jason, just to give you a shot at that question, we're all historians here, so this is uncomfortable for us in some ways to be talking, although you have some of you have sociological chops too, so maybe you're a little more qualified than me. But what might you be expecting in the next few months, particularly? I mean, I'll tell you, one of the things I'm worried about is, as we go off an economic cliff, particularly for essential workers and people who are the most precarious in the economy, and if relief doesn't come, that there will be a narrative of, it's already there, a narrative of blame for those people for not having saved money. I mean, we see this with the disaster victims all the time. They should have been taking better care of themselves. There's already been these kind of ripples there. And even that Times story I read at the top, I think people may read that story differently, or that story might be reported differently in other news outlets about the dissolution of the family and in some ways, some of the themes we were talking about earlier, about children becoming orphaned because of the failures of parents. I worry about that discussion sort of emerging more explicitly here in the coming months. I don't know. Do you want to talk a little bit about what you're concerned about as we move into these next few months with COVID?
Yeah, I mean, I'm concerned that, the sort of rush to get kids in school without really knowing what the real effects of the disease on the children are. Moreover, what are these what's the web look like if these children are going back to school and then coming home and then getting their parents sick? I mean, we're already seeing this story play out a little bit where people are concerned that, like, okay, well, the child could get their parents and grandmother sick, and that could lead to parents dying and so forth. That would be a big concern. I think where there's also a corollary with HIV, I think, and that is, again, this kind of the discussion of structural inequalities now has almost become normalized in our discourse, but that's about it. I mean, to actually do something about those problems is what I'm waiting for. And I'm worried that, like, once a vaccine comes out, whenever that comes out, or there's some other kind of techno-scientific solution, that a lot of this stuff, again, is going to get, swept under the rug. Because a lot of the stuff that, that could help the children with COVID are things like mitigating childhood poverty, or just ensuring that every child from conception to 18 has health care, and these kinds of things. Like, if, in other words, like, if the country wants to put their money where their mouth is, they would pony up and be like, if the children really are this precious resource, right, then we're going to give them all the resources we can. So my fear is that, like, we're going to have this discussion about inequalities, but that's where it's going to stop. And maybe a third thing is that the children, again, are going to maybe be overshadowed by other conversations. And it's tough now too, because there's so many other things. It's not just COVID. It's, the election's coming. I mean, there's all kinds of other anxieties that, are going to dictate some of these narratives. But nevertheless, I think as scholars and even as just, good Republican citizens with a little r, that we're, sort of being, stay aware of these issues and not let the children with the disease being overshadowed, and especially the things that are making the disparities a big problem.
Janet, I mean, Operation Warp Speed, certainly the Trump administration would like to have all of our attention focused on pharmaceutical companies, and I'm not here to criticize that effort, but to have to choose that over a thoroughgoing American discussion about structural inequality and racial violence seems like an awfully huge missed opportunity, doesn't it?
Well, it's an opportunity we've missed for several hundred years. So as a historian, I think it's fair to put that out there. I want to point out two quick things. One, maybe because I'm not from Texas, but as a Californian, I will tell you that the highest rates of COVID are in our Pacific Islander communities on the West Coast. And they often get left out of that discussion. I'm concerned about the discussions. There's an Operation Warp Speed for vaccine, but there's also a lot of discussion coming out of the White House about herd immunity, which translates to a eugenic, let those old people die so those parents, and let the kids go to school and get sick, and then the parents can get back to work. So that concerns me. And the other thing I think we need to keep in mind as we're living in COVID real times, but this is a virus that we do not know much about. We do not understand. We do not know the long-term consequences of exposure to that virus. We know from the 1918 influenza that those people who were exposed had much higher rates of Parkinson's disease in old age when they were exposed as children. What are the long-term consequences for children who have COVID? Does it do permanent brain damage? Does it do heart damage? Does it do lung damage? Does it do kidney damage? Does it do some kind of systemic other kinds of damage? We don't know the answer. So it is very cavalier to say, well, the children aren't dying as much and we don't see pictures of them, and old people are old and sick anyway, and we have to get those other folks back to work. That's a very short-term view of what will be potentially an enormous long-term problem of health placed on top of the structural inequalities that give us a healthcare system that is full of holes, that is undemocratic. It's demographically corrupted by where you live, who you are, how much money you have, and that's facing, as we face the potential loss of our existing access to health insurance.
We're almost up on time, but I just want to follow up on that, and maybe everybody could take a turn with this. Janet, thank you for your correction. I mean, you consider the longer stretch of American history, it would be surprising if we looked at structural inequality seriously in this moment, because it just has not been the American tradition. But I'm really impressed by some of this, insights you have about, the 1918 influenza and those children as they become adults, and the health impacts undoubtedly exacerbated by the Great Depression. I mean, these disasters have to all be taken as a complex. They can't be separated out independently. So let me ask you, though, if you know of examples where moments like this can lead to activism. In other words, they can open possibilities for the way we think about healthcare in the United States. And you may have to turn to other countries for examples for this, I don't know. But I'd be curious to know where you do find possibilities in these moments, particularly around children, which, as you've all pointed out, children become a sort of battleground for the way Americans think about who deserves and who doesn't deserve health care. But I don't know, Janet, can I give that to you first? If you can, I'm not asking you to give us an optimistic story on the way out the door.. If it doesn't exist, that's fine. But I'm curious about activism in this moment.
Well, activism, I think, will come from many places, but certainly the conjunction we have now with the COVID risks being exacerbated by structural inequalities and a heightened awareness of the ongoing racial divides in this country that lead to all kinds of bad outcomes, whether it's encounters with law enforcement or whether it's encounters in trying to rent an apartment or trying to access health care. I think that does lead to a vigorous civil rights activist movement, and that will spill over. But will it happen? Will it have permanent structural change? I'm not going to speculate on that. Maybe I'll leave it to Jason and Stephen.
We'll bring you back in the spring for that, I guess. Stephen, what about you?
No predictions here. Every story of activism and accomplishment that comes out of these kind of health and disease activism around children are all double-edged, kind of, in my experience. They have a lot of short-term gains tied to them, and some kind of, they have this arc of, delivering some kind of limited form of justice. But in the broader perspective, they're always, I don't know, in far less than what we would hope. And, so to go back to the hemophilia activism, for instance, in the 90s, coalesces around kids like Ricky Ray. And when the hemophilia community, about 90% of people with hemophilia in the United States had HIV or Hep C in the 90s. They were seeking restitution from the federal government for the lack of oversight by the FDA, from Congress. In 1998, the Congress passes the Ricky Ray Hemophilia Relief Fund to provide restitution, $100,000 per victim, every family, and that's kind of the example. Like, it's justice served, but is $100,000 per, loss of life? Is that restitution? Is that reconciliation? Almost everybody in that community says it was a good start, but it wasn't enough. $100,000 didn't even cover a year's worth of clotting factor concentrate for a hemophiliac in many instances. So it but I don't want to denigrate the hemophilia activism, because it was extremely effective in its moment, and it tried to hold up a mirror to the government and to the pharmaceutical industry and say, this was abusive. And, they did get held to account to a small degree, but the wheels of biocapitalism move on. And the next generation of hemophilia families aren't necessarily even aware of that struggle that happened.
Jason, I want to give you the final word on this. It's a tradition for the person who's just defended their dissertation always gets the final word. It's a new tradition. I just created it, but it seems appropriate. There's a lot on the table here, though, I think, particularly, and I think some good caution, tempered optimism, and Stephen, as a polite and careful refusal of my binary that we can either be activist or non-activist, but for looking for the complexities within that moment. I'd like to see where you'll take us out with this.
Well, I'm an eternal pessimist, so it's hard for me to see any of this getting better. But particularly because, and Janet knows this very well too, in that there. COVID, pediatric AIDS, tuberculosis, Cindy Connolly shows us this in her book on tuberculosis, right? I mean, there are just numbers, these diseases that are associated with or exacerbated by poverty. This is not new, right? I mean, and so what the response is going to be is a big question mark. I don't No, though. I mean, because right now we're going through what, the third greatest racial reckoning in our nation's history. So maybe that if children's health can be kind of incorporated the way that the civil rights activists in the second great racial reckoning of the 50s and 60s incorporated health inequalities into their activism, maybe that's a way forward, you know, and a way of saying, like, well, if not for everybody, at least for kids, right? At least we have some kind of support, government support. We're going to need some kind of actual institutional support for this to happen. If we're not going to do it for everyone, do it for the children, get them free access to healthcare, get the kind of mitigation resources necessary that will help kids not have long-term health effects from these problems and others. That would be my take, if it can somehow get kind of consumed into this broader sort of push that's going on now. And hopefully that's it. So actually, as a pessimist, that sounds pretty optimistic. So I don't know. It's
So.
like, yeah, maybe I'm converting. I don't know, but yeah.
Well, I promised the panel we wouldn't go past 6:10, and like every conversation I've had this week, we've gone long, and I really want to thank the panel for this conversation. And I want to remind everybody that you've been listening to COVID Calls, and you can catch COVID Calls every weekday at 5 p.m. Tomorrow, I'm going to be talking to Olivia Troy. Her name may sound familiar to you. She was a member of the coronavirus task force, and she has left government, and we'll be talking with her tomorrow about that. Very much looking forward to that. And I want to thank Stephen Pemberton, Jason Chernesky, and Janet Golden for this conversation today.
Thanks, Scott, for having me.
Thank you.
Thank you.
Stay healthy, everybody. We'll see you tomorrow, 5 o'clock.